Good morning, everyone. For those I haven't met, my name is Emily Field, and I'm an evaluator here at USET. If you haven't done so already, I'm going to invite you to mute yourself unless you're talking or presenting, and please don't take offense if we mute you. Please type any questions you have into the chat if you have them during the presentations, or you can ask them out loud at the end of the presentations. If you have not attended one of these before, please share your name, affiliation, and email into the text, into the chat box. If you're just joining us by phone and you're not already on our contact list, my email is efield, that's EFIELD, at usetinc.org. You can send me an email and I'll make sure you're added to our communications. And we are recording this. We've already started recording. Towards the end of the session, I will be sharing an evaluation link in the chat. If you could please click that and give us some feedback. We want to make these as useful as possible. And that's all I have.
Thank you. And Talo, if you want to introduce the staff that are presenting today.
Yes, good morning, everyone. So today we have Christy doing her usual updates on testing numbers in the IHS Nashville area, and then COVID updates from Dr. Mira from Cherokee Nation, and a presentation on dental safety precautions from the USET Dental Support Director, Frank. So I'll go ahead and pull up Christy's presentation.
Good morning or afternoon, everybody, I guess, depending on where you are. Thank you, Tilo, I appreciate it. Just a very quick update before I turn it over. Who's going to go first, Dr. Mira or Frank? After me. Dr. Mira?
Yeah, I will go next. It's fine. Thank you.
Okay, all right. So just a quick update on what's going on in the USET area regarding COVID-19. If you could go on to the next slide. As of yesterday, there were 26 tribal sites reporting to the IHS Nashville area office. We have 6,276 tests being conducted so far, and that's up from 5,484 from the previous week. We had a jump in positives from 777 to 909. And then the number of negatives, of course, went up correspondingly as well, from 4,302 to 5,542. So we are seeing an increase in numbers. And if you proceed to the next slide, sorry about that. We are seeing a corresponding increase in rates too. It does look like that we are not progressing more rapidly than what the U.S. is doing, but we are consistently somewhat higher in our CHISTA counties. This is not tribal specific data. This is data taken from the state public health websites, and we looked at it from the USET states, all 13 USET states, and then we also drilled down on a county level and combined all of the CHISTA counties. And so you can see our CHISTA counties have been consistently higher across the board than the U.S. rate and the USET states rates. So that is concerning to us. We are keeping an eye on that, and we'll keep you updated as to the rates. So if there are not, if there in these, these cases are per 10,000. I know that you probably see per 100,000, but for our tribal communities, we feel like per 10,000 is a little bit more meaningful since our tribal communities are generally smaller. So we are seeing right now 87 per 10,000. As always, what is it that we can do to improve upon? What are your challenges during this pandemic? Where do you feel feel most supported and least supported. We are very interested in these questions. So if you have any thoughts, that will help us drive our services that we are able to offer to you guys. And these are just general thoughts we would like for you to consider during this presentation and as you navigate this pandemic, and reach out to us should you need any assistance. And as always, here's our contact information. The best way to get in contact with us is usetepi@usetinc.org. That said, we realize that many people like to contact who they know, and the USET staff is in close communication. So we'll just, if you don't know who to contact who you know, and it will get routed to the correct person. So I'm going to turn it over to Dr. Mira. I'm interested to hear what's going on this week. It seems like this week has been a really long week. And to me, it seems like there's been a lot of changes in what we know fairly recently. So I'm interested to hear what you have to say. I'll turn it over to you, Dr. Mira.
Thank you. Okay, before I start, Christy, thank you for your presentation. And what you are seeing is what we all are seeing. It's an increase of the numbers, which is not surprising because things are opening. But it's not only due to that fact, is because I think the messaging to the general population, at least where I live, and I'd like to hear later what other people are seeing, is I went yesterday, I had to go to do a chore in the mall, and I think I was one of the few persons wearing a mask, and 95% were not wearing a mask. The shops were kind of following some guidelines. They were not allowing, X number of, more than a certain amount of people in them. And they were asking people to wear masks, but they were not enforcing it. So what's happening is not surprising. And I think we have the obligation to, try to tell everybody we know and we can that they should be wearing a mask to protect other people. But yeah, it's a little bit sad. Okay, so I recently was in this symposium of, it's a European network, virology education. I do recommend it if you want to jump in. Sometimes they have some interesting stuff. And I thought I wanted to share what I saw that they presented, which is a good summary of where we are with serology, not going to the technical things that we see and presented, but just what is the use of serology today. So before we look at that, this is a really nice illustration of the different tests that we obtain in relation to the timing of infection. So it's here, if you see 0, that's when the onset of symptoms that a patient with COVID-19, if they have symptoms, they present, this would be day 0, and on the rest of the X line goes up to day 60. So if you're seeing a patient within the first week, your PCR test and antigen, if you're using that, are the best tests to diagnose the infection in that time period. When you're transitioning from day 6 or 7 through 14, there is like a little window period here that you may have a blind spot depending on the patient. Any test could be negative, PCR, antigen, or even antibodies. Then the antibodies start rising, and by day 10 or 14, the majority, actually more for day 14, it's the highest, it's the peak of the IgG antibodies. And then as time goes on, the IgGs will stay, the IgMs will drop. So I think it's a good illustration of when you're seeing a patient, okay, how many days has it been since they started with symptoms? What would be the best bang for my buck on what test to order? And you can do it based on this information. So the other thing that I found very interesting, and some of you have heard it because I presented this Wednesday in the Portland Echo. So this is from New York Times, but they obtained the data from reputable sources. And these each graph shows you, or each dotted graph shows you the percentage of the population which tested positive in each of those cities. Now, these are not strictly comparable because they're not all population-based studies, and that is reported in this series. But on the first, excuse me, on the first graph, you see what would be the ideal if the antibodies that the patients develop are, give you immunity. Taking that assumption, you would need at least 60% of the population to have detectable neutralizing antibodies for you to say, okay, that it's very unlikely that the virus will disseminate in this type of population. When you look at New York City, about 20% of the people is estimated to have positive antibodies, London 17%, Madrid 11%, and all of these cities have been, most of them have been hit pretty hard. The ones that have not, like Stockholm, 7%. But as you can see, none of these cities have reported more than 20% prevalence. So we are setting ourselves up for a second wave that I believe it may be occurring in the United States right now. So antibodies can be used for public health information, and they are very important in understanding the epidemiology of COVID-19. But it is important to clarify that there's no role in knowing the prevalence of antibodies the way we had with the information we have right now in determining when to relax social distancing or any other measurements like mask use, etc. Because even if current measures, the measures meaning use of masks and social distancing have a modest impact, the majority of the people are still seronegative. So you wouldn't want to pull these measures away because of that. And again, even if you determine that your population has a high percentage of antibody, we still don't know if this seropositivity guarantees protection against the virus again. We hope it does, but we don't know that for sure. And even if it would give you immunity, we don't know for how long that immunity will last. You know, there's many examples in infectious diseases, like when you get hepatitis B immunity through a vaccine, it's lifelong, but influenza, you need to get your shots every year. So it depends on the infection and the types of antibodies it produces and the mutation of the virus that will determine if your antibodies are protective or not. And the other example is hepatitis C. It's not protected. You can get reinfected again and again, even though you may have antibodies. So the applications, the clinical applications of serologic tests for COVID-19 could be used in 3 different scenarios. One is for primary diagnosis, meaning you're using the test to diagnose the disease, for retrospective diagnosis, or as a information to use to decide who can go back to work or not. That's more in a question mark. So for primary diagnosis, I show you here the same graph I showed before. And you know, occasional patients may have a clinical scenario very suggestive of COVID, but despite that, their PCR or antigen are negative. And we do see that frequently in the hospital. Patients who are admitted with a glass round opacities on the CT scan, they have lymphopenia, they've been in contact with someone with COVID, nevertheless, their PCR is negative. So if an antibody is positive at that time, it would help to say, okay, yeah, this probably could be for COVID-19. But usually that's after day 6 or 7. So a patient with a compatible clinical scenario after the first week, serology could be helpful if positive in confirming the diagnosis. But as I mentioned, after day 7. Now, the reliability of that diagnosis depends entirely on the performance characteristics of the test that you're using, and that has been discussed in this meetings before. So not all tests are created equal, and we are still trying to dig for more information how useful they are. So using serology, because that's been announced a lot by mayors of different cities. Okay, we're doing massive testing to see who can return to work or not. But as of today, really, this is not scientifically supported. Why? Because the majority of the people that you test will most likely be seronegative. So you shouldn't be using that as a criterion to go or not to go back to work. The criteria you should be using is how safe is your workplace, and are the prevention measures being implemented, basically physical distancing and mask use and disinfecting the area where you work. If the antibodies are positive, there's no guarantee that you can tell that individual, go back to work, you're fine, you're not going to get the infection, because we don't know if we have protective immunity yet or not. And it could give the false message that if you are antibody positive, you're not at risk of getting the infection, and maybe you relax on your use of PPE. And so that's not true either. So it shouldn't be used for that, at least with the information that we have today. For retrospective diagnosis, when the pandemic started, not everybody accessed medical care because they were not sick enough, or maybe they didn't even have access to it, or there were no tests. Remember, now we have testing. In the first week or two of the pandemic, we couldn't get a test done on anybody. So if those individuals are interested in knowing, did I really have COVID-19 when I got sick a couple of weeks ago? Yeah, and a positive IgG would help tell you that most likely the patient got infected, but that's all the information you would be getting, not if you're immune or anything like that. Some work jurisdictions or workplaces are requiring testing to return to work, but actually what you really want to know, if you put that requirement, if the PCR is positive or not, because you really want to know if the patient could be contagious, that's all, or the worker could be contagious. So antibody testing doesn't really play a role there either. And many healthcare workers want to know, they've been working with COVID-19 patients every day. Some may have had symptoms, some may not, but they want to know if they got exposed or not, especially because they're asymptomatic cases. And that would also be, if you have the money and the capacity to tell the workers. It could also have another measure of how good your PPE is being used and how protective it is. If you would measure antibodies in your healthcare workers and see how many of them are positive. But having said that, many people don't. We have a lot of healthcare workers who've gotten infected at home, not in the hospital setting, and we know that because they have had a contact at home who had the infection. So still, it's not black and white, but it's things to consider. Okay, switching gears a little bit. There was one more. So the information we had about the utility of convalescent plasma were basically two small case reports, one of 5 patients, the other of 10 patients in China who were on ventilators. They reported good outcomes, and I presented this data maybe a month or 2 ago. This study came out recently published. It was an open label, multi-center randomized trial in China, in Wuhan, and they randomized patients to receive convalescent plasma or not. Now, these patients, the caveats with this study is that the convalescent plasma was started pretty late in the course of their disease. Even the majority of patients was after 2 weeks, and some even 3 weeks. And so, they were randomized to receive plasma or not. And they expected to enroll 200 patients, but they were cut short with 103 because the pandemic went away, and then they didn't have any more patients. That was a nice reason why you couldn't complete your study. The bottom line was that all the data is here for you to have, and I'll send these slides, but there was no significant difference in the 28-day mortality between those who received the convalescent plasma compared to those who did not. But many of these patients were also receiving other treatments, so it's difficult to tease out what the effect of plasma and the other treatments were. But they did notice that the individuals who got plasma did have a higher negative conversion rate and sooner, sooner conversion rate compared to the ones who did not, meaning their PCR 87% of the patients who got plasma, their PCR for COVID was negative within 72 hours, compared to only 37% of the control group. So their conclusion was that among patients with severe or life-threatening COVID-19, convalescent plasma therapy added to standard treatment compared with standard treatment alone did not result in a significant, statistically significant improvement in time to clinical improvement within 28 days. My caveat with this is basically that the timing of the initiation was very late. We are using plasma in our facility, and we offer it on day 1 when the patients are admitted, and usually by day 2 or 3, if they accepted it, they're getting the convalescent plasma transfusion. We've treated 7 or 8 patients so far. Of course, we do not have a randomized controlled study. We just offer it to everybody. And so far, these patients have done well. But I think we have to wait for a randomized controlled study that evaluates this treatment modality in the first few days of the infection, and not so late. This was a randomized trial of hydroxychloroquine as post-exposure prophylaxis. So basically, if an individual was exposed, they were offered to start hydroxychloroquine, and the exposure was defined as within 6 feet and more than 10 minutes, not wearing proper PPE in the presence of a COVID positive patient, or actually, that's the tricky part, or patients who had symptoms compatible with COVID. So this study, in my view, has 2 problems. One is that not everybody was COVID proven, the people who got exposed to. And the other one was that they started 4 days after, and that seems too long. Now, it could have been just the nature of the study, because when you do contact tracing, you find a case, and then you try to track down their contacts, and it might take a day or 2 until you reach them. But in my experience with post-exposure prophylaxis and many other viral diseases, like influenza or HIV, you have to start like really quick, and some within hours and some within a day. But usually very few of them will allow you to start after 4 days, as long as 4 days. So they measure the primary outcomes, and you can see the results here. And the other thing that caught my eye is that when they looked at laboratory confirmed diagnosis, it was only 11 patients on the hydroxychloroquine group and 9 patients on the placebo group. And then they also evaluated symptoms compatible with COVID-19. And we know that that is a little bit iffy, because 95% of the individuals who have symptoms compatible with COVID don't have COVID. At least that's our experience, and most of the experience of everybody. But they included this in the study. Nevertheless, neither on the laboratory confirmed nor in the symptoms compatible COVID was that there's a statistical significance. So the bottom line was that in this study, hydroxychloroquine as post-exposure prophylaxis did not seem to have any impact. And of course, as expected, side effects were more common with patients who received the hydroxychloroquine. So still, although I'm not a very firm believer in this drug from all the data that I've seen, I think this study could be improved using only COVID positive individuals as their outcomes, and starting prophylaxis within at least, less than a day before exposure, after exposure, because the incubation period of this virus is 2 days. Regarding immune-based therapy, I mentioned maybe a couple of weeks ago with you the Italian experience with anakinra, which was pretty promising. I did give you what's up to date today with convalescent plasma. And there's a list of all the other IL-6 inhibitors and JAK inhibitors that are being evaluated, but there's still not robust results from any of these trials to give them the green or the red light for future use. But I do believe that there will be a role for these immune modulators in individuals who are in the immune phase of the disease, which is usually after 10 days or 11 days of illness. These are the references for these studies. And I think I presented to this group a study in Atlanta showing that African Americans had higher rates of COVID-19. And this is another study in Louisiana, and they looked at the health system, the Ochsner health system. Their COVID, what they did is compared their non-Hispanic Black individuals with non-Hispanic white individuals in regards of diagnosis and outcomes of COVID-19. The majority of these patients were 54 years old, the mean age, most of them were females. Interestingly, they represented only 31% of the health system population, but Black individuals represented 70.4% of the COVID-19 patients. So COVID was more frequent in African Americans than in whites. Now, the other things they found was that African Americans were more likely than the white population to have pre-existing conditions, meaning diabetes, hypertension, COPD, and also to present with respiratory symptoms such as cough, fever, and dyspnea. Also, the Black population had twice as much chances of living in a low-income area and 3 times as likely to have Medicaid. And these were factors associated with hospitalizations. But after risk factor adjustments were done, the in-hospital mortality was independently associated with the age and with other clinical measures, but not with ethnicity. So, in summary, being an African American in this health system, for whatever reasons that may be, and it could be, social or economic factors, they were more exposed. They were more likely to acquire COVID infection. But once they have it, they are not more likely to die from it compared to the white population. And these results were very similar with the Atlanta studies that I presented last time. So it's important to have studies from different areas showing the same results because the data is reproducible. So, this is in the UK, and then what they did is they looked at also racial, minorities. They found that racial minorities were disproportionately represented among pregnant women that were admitted to the hospitals with COVID-19. And they studied 430 females that were pregnant. 56% were Black or other ethnic minorities. The majority were overweight or obese. They usually would be admitted on the 2nd and 3rd trimester. And their outcomes, 10% required respiratory support and 1% died. This does not seem to be very different from other populations, non-pregnant populations. But they had 5 babies that died. 3 deaths were not related to COVID, and there were 2 stillbirths that could not be explained if COVID had a role or not. The authors of this study, their conclusion was that they need to look in why are these racial minorities being overrepresented, and it probably boils down to socioeconomic factors and access to healthcare, maybe. Although in England it's socialized, so I'm not sure if that's a fact. And last but not least, I just wanted to show you, this is a study of a SARS-CoV-2 infection in a Navy ship of the United States, in which the majority of the individuals were infected, a great proportion of them. But they looked at what was the risk factors of infection among those who reported wearing a mask or a face covering, that avoided common areas, and that observed social distancing. And as you can see, the rates were lower than the ones who did not do this. So I think this just reinforces that these measures do help. And also in a situation that is as crowded as it can be, I think the only situation it's going to be more crowded is if you're in a submarine. That the measures do help, but they're not perfect. And also interestingly, almost 60% had neutralizing antibodies. So that's another piece of information that the antibodies that are being produced during this infection at least could have immunity, but we don't know for how long. And that is it. Thank you.
Thank you, Dr. Mera. There's a couple comments in the chat.
Okay, let me see.
From Dr. Brown.
Yes. Is there any evidence available to say that the early use of convalescent plasma would be beneficial? So the answer to that part, no, there's no evidence yet, but there is a hypothetical. So a couple of weeks ago, I presented this chart of when, hypothetically, when would therapies be most effective? And antivirals and antibodies would probably be most effective in the early course of the infection. And immunotherapies like IL-6 inhibitors or IL-1 inhibitors or JAK inhibitors would probably be more helpful in those individuals that are being admitted to the hospital and have advanced advanced respiratory symptoms where the immune part of the COVID-19 infection is taking place. But there's no data so far if it is helpful early or not. And I hope we get that information soon. So it seems that with most experimental treatments, and right now all treatment is experimental, that's a good point, that our antiviral treatments, we are studying their efficacy when used late in the course of illness and in the severity. Yeah, I agree with you. I think that's a problem. You know, from the experience we know of other viral respiratory infections, specifically influenza, you have a very short window to treat influenza with oseltamivir and have some good effects. It's 48 hours from onset of symptoms. And actually, it's actually 36 hours. And the shorter the interval, the better the outcomes. So I think we should be doing that also. The problem is that the only antiviral that's been approved, which is, emergency approved, is remdesivir. And right now, the criteria are that you have to be hypoxic. And although Gilead showed some data that non-hypoxic individuals with pneumonia would benefit, that still has not been a formal recommendation. We at Cherokee Nation, we are using remdesivir for all the hypoxic individuals and also for some people who require admission and have pneumonia. But if it was up to me, and of course we need to wait for the randomized clinical trial results. But I think anybody who comes in with a COVID infection that has severe comorbidities and at high risk of developing having a bad outcome, that's the group that I would like to try the antivirals and see if they work or don't work. The other problem is that remdesivir is only intravenous. So it would be very difficult to have this antiviral given to everybody who got infected. I know that Gilead has mentioned that they were working on a nebulized formulation of remdesivir. You cannot give it orally because it is completely inactivated in the liver. But there are, hopefully there will be other antivirals being investigated. And I agree with you, Harry, it should be early, not late. Excuse me. Do you know how they measured neutralizing antibodies? In the study that I presented, I don't. I don't remember if they reported it or not. I'll look at it and I'll get back with you on that one. But usually they should have used the cell assay in which you expose the plasma to see if you can prevent cytotoxicity of the virus in a cell culture. But I will check on that. Is the use of convalescent plasma timing-wise a hospital protocol or an individual physician decision? In our hospital, anybody who requires admission because of COVID-19, now requiring admission is a criteria that depends on the urgent care or ED provider. They usually use the usual admission criteria for near respiratory infection. As soon as they hit the bed, we offer them convalescent plasma, and we explain that it's experimental, but we can get it for them. And we also, if they have a pneumonia, we also offer them remdesivir. So far, we've treated 4 patients with remdesivir. 2 of them are still on treatment, and I think the other 2 already recovered and are fine. I think that's it, right?
Yes. Are there any other questions for Dr. Mira? If not, we'll move on to Frank. Frank Light.
Good morning, everybody. So we just want to talk a little bit about, safety precautions that we can do in the office as we're working every day, just to help quell the transmission of the virus while we're working. So you can move to the next slide, please. So one of the things you can do is try and include temperature readings of your patients as part of the routine assessment prior to performing any dental procedures. This just gives you kind of a base of where the patient is at, just to help you out. Make sure you're using your appropriate personal protective equipment, your mask, gloves, shield, face shield, gown, and your N95 mask or a surgical mask. If you're doing certain procedures, a rubber dam is recommended. This just helps to decrease any possible exposure to the infectious agents if the patient is infected and you don't know it. And on any procedures that you're going to produce any kind of aerosol, you're going to want to use a high volume evacuator with that. Make sure you're autoclaving your hand pieces after each patient. This is an imperative just to make sure you're using clean utilities for that patient. One thing that we did when I was in dental hygiene school is we had our patients rinse with like a Listerine rinse, just a pre-procedural rinse. And they're recommending you do this with 1.5% hydrogen peroxide before each appointment. It's stated that COVID-19 is vulnerable to oxidation, and this helps to reduce your salivary load of the oral microbes. You'll want to make sure you clean and disinfect your public areas frequently, including door handles, chairs, counters, bathrooms, and you want to remove from the front public areas any kind of magazines or reading materials or toys that are not easily disinfected. All right, next slide. All right, so questions have been asked, can you wear the same mask for more than one patient? And it's not recommended you do that. The CDC recommends single-use disposable masks, and make sure these masks are approved by the FDA. Make sure you're wearing a surgical mask, gown, and eye protection with solid side shields on your glasses if you're not wearing safety glasses themselves. You want to wear a face shield to protect the mucous membranes of the eyes, nose, and mouth during procedures likely to generate splashing or spattering of blood or any fluids. You want to make sure you're changing your masks between each patient or during patient treatment if the mask becomes soiled at all. And that's why it's best to use your mask with the face shield to help prevent that as well. All right. So identifying patient symptoms, one thing you can do is you can ask your patients different questions. You want to have the ability to triage these patients, screen them, and minimize the risk of COVID-19 transmission to the healthcare providers and to other patients, obviously. So some of the questions you can ask them is, has the patient traveled internationally in the last 14 days? Have they been in close contact with another person who has been diagnosed or who is under investigation for COVID-19? And then another question you can say, is the patient, do they have a cough, fever, or shortness of breath? So you want to take those answers. If they answer yes to any of those, you can then refer them to a hospital or a clinic for further testing and evaluation. The ADA cautions, though, they want to take these recommendations. They're not directives. They're not legal directives. They're just advice and legal, it's not legal guidance. It's just saying, hey, these are some guidelines you should follow just to help yourself out. And again, if you have patients decline them, then again, it's not they're not required to do things. These are just things to help you out. Next slide. All right, social distancing. We've heard this this term for months, right? CD recommends using social distancing whenever possible in an effective way. You want to have your patients arrive on time for their appointments rather than too early or too late, since this will minimize the amount of time they spend in the waiting room or reception area. You want to try and schedule your appointments where you can minimize possible contact with other patients in the waiting room. Let's see, again, you want to remove your magazines and reading materials that are not easily disinfected. All right, slide number 6. Go to the next slide, there you go. So if you have an employee that's exposed to COVID-19, you're just gonna follow the standard procedures. You're gonna send them to the local health department, state health department. Or you're gonna report that to the local health department or state health department. But you're just gonna follow the same procedures. You're just gonna have them tested and treated if necessary. All right, one of the biggest things that I've been reading about is what's called patient abandonment. You don't want to have your dentists be accused of abandoning a patient. So transparency is the key. You want to be able to send your patients, it's recommended you send your patients a letter just to show them or explain to them what you're doing for these recommendations for the COVID-19 protection, so what they know what to expect when they get to the office. All right, so you want to give this letter. You want to follow the ADA guidance on different dental care that you're providing. Not all non-emergent appointments, including prophylactic care. You know, just let them know what you're doing, and you want to give them like a 3-week window of what you're doing. Okay. You want to make your dental records available to patients upon the office receipt of a HIPAA-compliant release. Dental staff should continue to answer phones and respond to any questions that may arise and any emergencies that may arise. And the dentist should try and make himself available for consultation via phone or in the event of patient needs. All right, N95 protocol. Obviously, you want to use the N95 respirator when you're doing any kind of procedures that aerosols are being generated to protect yourself. If the respirator is not available for an aerosol generating procedure, you want to use both a surgical mask and a full face shield. You want to use the highest level of surgical mask available to you. If the surgical mask and full face shield are not available, it's recommended that you not perform any aerosol generating procedures. All right. You want to discard the N95 respirators following use of aerosol generating procedures. Consider the use of a cleanable face shield, right? It's easier to clean that than to throw the mask away each time. And then considering using the mask, how many hours should we use the mask? I've heard anywhere up to 40 hours. What I'm seeing here is the maximum recommended time you should use an N95 mask is about 8 to 12 hours. And then respirators should not be worn for multiple work shifts and should not be reused after that extended usage. The last thing you should think about is making sure that your N95 masks are fit. There's a fit kit that you can purchase or that you can get from the CDC in different places to make sure that it fits your face properly. And then there's also different companies that can decontaminate those masks for usage if they've not been used for extended times. I think that was all I had. So does anybody have any questions?
Emily had a question in the chat.
Okay.
Let me find it. When will it be safe to have one's teeth cleaned?
Well, we're still waiting on that. I think you can do regular procedures now. So a lot of dentist offices are starting to open, at least locally. What they're doing is they're doing low-level procedures, and if they can
100%.
postpone the higher level procedures, that are producing, they're postponing that. But remember, even a rubber cup prophy can produce aerosol. So it's just a matter of keeping safe and following the protocol in the office.
Great.
Hey, Frank, Frank. I have a question for you. I'm sorry to interrupt. It's Joe Solomon from Seneca. Frank, I know you mentioned the peroxide 0.15 solution, but are any other oral rinses being advocated or recommended at this time besides that one?
That's the only thing that I saw at this point. But like I said, when we were in school, we were using Listerine, and that was accepted as well. So, but I'll research that and see what I can.
I was just wondering because I have like an overabundance of chlorhexidine gluconate, so I was just wondering if that's, something I could, utilize if that also oxidizes or denatures the virus and stuff like that. So
Let me look at
yeah.
it.
Okay. Thanks, Frank.
Welcome.
Do we have any other questions for Frank? If not, Emily, if you will put the chat, okay. There's the survey in the chat box. If you will click on that and fill it out and give us some feedback on today's echo. Do we have any other questions for any of the presenters? If not, we'll go ahead and end today's echo. Thank you, everyone. Don't forget to do the survey.
Have a good weekend.